Assalamualaikum. Assalamualaikum. So this is an overview of bleeding disorder. I'm Dr. Ayesha Nageen. Again, the same thing that I'm going to emphasize again, that this is not a replica of your attending a class. This is just sharing of the slides. Okay. So what is hemostasis? Hemostasis is the arrest of bleeding from an injured blood vessel. So this is a natural mechanism that we have to, when there's a certain bleeding, there's a hemostasis process in which the blood vessel, that injured blood vessel, is supposed to stop bleeding. And for that, there is certain regulatory markers that are supposed to be in helping them to stop the bleeding. So there's a primary hemostasis where there's a vessel wall function and the platelet functions of adhesion and adhesion. So as soon as there's a bleeding or a cut, the platelets come forward and they together they aggregate and they make a primary plug. But this is a very temporary plug. And there's a secondary hemostasis where the coagulation factors are activated and there's a fibrin deposition and a clot formation. And then the clot is formed, and then the clot is, after the fibrins completely, the clot is formed and the skin is healed. There's a clot retraction, which means that the clot then the clot is falls off, and then there's a cross links of the fibrin. Okay. Any compromising homeostasis at any stage leads to a bleeding disorder, right? So what are the symptoms of bleeding? We know what a bleeding is. You can have bruising, you can have bleeding gums, you can have heavy bleeding from small cuts or dental work, you can have an neck pain, nosebleeds, heavy menstrual bleeding, bleeding into joints or excessive bleeding following surgery. And all these bleedings are abnormal. And if there is a certain bleeding disorder, then we need to look into four different circumstances that can happen: vascular abnormalities, platelet disorders, clotting factor abnormalities, or TIC. So any of these four can be the cause of a bleeding disorder. So causes of bleeding, again, vessel vascular and platelet disorders, coagulation factors, or a combination. So approach to a patient of bleeding would first you take a history, you take the clinical features, you find out where the bleeding is, and you try to guess that what is the cause of the bleeding. Is it due to vessel wall dysfunction? Is it due to platelets abnormality, or is it due to coagulating factors, or is it a combination of everything which is DIC? Then there's a laboratory approach where you see the screening test and the second line screening test. So you find out that whether the bleeding has happened before or not, and what was the first time that this chronic bleeding disorders have started, the family history of bleeding. Do you have anybody else's bleeding as well, spontaneous or after trauma, time of manifestation after injury, or ease with which the bleeding is controlled, and the drug history. Are you taking any drug that can cause bleeding? Physical examination, you assess the volume status. Have you bled a lot? Is he in a hypovolemic shock? You look for hepatosplenomegaly. Is there some kind of aplastic anemia or some kind of platelets disorder? You look, do a rectal examination. Is there GI bleeding over there? Because that's a hidden bleeding. You look for petechiae. Petechiae are small dots for bleeding, like that source of when there's a loop platelets. Hereditary telangiectasias, you look for that in the nail. You look for gum bleeding, gum hypertrophy. That is due to leukemia. You can look for telangiectasias, which are blood marks on the nails. Angular stomatitis, subcongenital hemorrhage, or purpura. So any signs of bleeding anywhere. So the test for coagulation factors, okay, so if you determine that, yes, there is a bleeding disorder, you need to do a test. So the test, the basic screen tests are PT, for thrombin time, APTT, activated PTT, thrombin time, fibrinogen assay, and a platelet count or a bleeding time. So we need to see that's for platelets. So if I feel that there's a petechiae and there's a platelet problem, then I'm going to look at the platelet count and the bleeding time. If I see this, if I feel there's a coagulation factors, I do a PT, APTT, these two. So basically we do all four of them just to just to be sure. So platelet count must be done in suspected bleeding disorders. And so you know what I've seen is we are going to talk about platelet counts later. Then there's a bleeding time. Bleeding time is how, if I put a cut, how long does it bleed? It is usually 2 to 7 minutes is normal. More than that is a prolonged bleeding time. Causes of a prolonged bleeding time could be low platelets because that means that there's no plug formation by the platelets. A von Willebrand disease or a platelet function disorder where the count is normal but the functions are Platelet function is another problem. That is when I suspected, when I feel that there is a platelet problem, the coagulating factors are normal, the platelet count is normal, maybe the platelet functions are not. So for that, there's a PFA, a machine that sees whether the platelets can adhere or aggregate together. And that is then that, and then you have to see whether there's a platelet function, determine blood function. Coagulation mechanisms and activation of platelet factors. A normal coagulation mechanism would be that after the cut and after the platelets have aggregated, then their clotting factors are activated. And they need a tissue factor intrinsic to the blood, and they need an activated factor intrinsic to the blood. These are the two chemicals that they need to get activated. And you need vitamin K in certain factors, which are 2, 7, 9, and 10. You need to remember them because they are vitamin K dependent factors. So if vitamin K is deficient, these factors will not be working. These are the list of the coagulating factors. This is the pathway that you guys are going to be, I'm sure you guys are going through it in patho. And so this is my final aim, the growth. So this is important for me. In the intrinsic pathway, 9 and 8A. So A means activated. So A converts 10 into 10A, and then both the 10s are then converted into 10A, and 10A with 5A causes both thrombin to thrombin and fibrinogen to fibrin clot. This is the important end result that I want. This is the outcome that I want. And that is basically the SCAG that is formed, right? So the important, for me, the important factors is 8A that we're going to talk about later, and that converts 10 into 10A. A is the activated form, and then plus 5, they convert both thrombin to thrombin, and then fibrinogen to fibrin. Factor A circulates in an inactive form, and it is bound to 1 milligram factor. In response to injury, coagulation factor, it is activated and separates from 1 milligram. So at A interacts with 9, forming a blood clot. So 1 milligram factor is a very important role because it also adheres to platelets. So it's also important in platelets. When the two aggregate, this is a median factor that causes the aggregation of platelets, and it is also the carrier of 8A. So 1 Willebrand disease is a defect in 1 Willebrand factor, and that causes the defective functioning of the platelets and the factor A. So it affects both the stages of homeostasis. PT and APTT. PT is a test for extrinsic pathway that we saw before in the common pathway. It measures the vitamin K dependent factors. So if there's a liver cirrhosis and vitamin K is not being formed, the PT is going to be prolonged. PT is 10 to 14 seconds. The clotting time is definitely going to be affected. So clotting time is how the time needed for the clotting that is going to be prolonged. Test for intrinsic and common pathways, APTT, and this is dependent on our activity of all coagulation factors except 7 and 13. Normal values are 30 to 40. It monitors heparin treatment and screen for hemophilia. So if there's hemophilia, then the factor 8 is basically deficient, and then ABTT is going to be deficient. So we're going to talk about that later. Vessel defects causing bleeding. So this is a diagnosis or exclusion. If there is a vessel problem, the blood vessel is thin, and it's causing the bleeding, then all the lab tests are going to be normal. It is a diagnosis of exclusion that I've excluded everything. I've excluded platelet problems, I've excluded coagulation factors, and in the end, there is a then I say that there might be a connective tissue defect. It can be hereditary or it can be acquired. Vitamin C deficiency can cause a scurvy, right? But all the lab tests are going to be normal in this. Thrombocytopenia is a low platelet count, less than 150. So it could be a decreased production, for example, viral infections, dengue, plastic anemia medication, or it could be increased platelet destructions like medications, transfusion reactions, and idiopathic thrombocytic purpura, which is an autoimmune disease where the platelets are destroyed. Okay, so no, 1 second. Or it would be that the platelets are consumed a lot, for example, in the infection or DIC or chemotherapy, or spleen has enlarged and it is causing the destruction of platelets. So these are the causes why platelet thrombocytopenia can happen. If you feel that there's thrombocytopenia, you're going to do a platelet count and you'll see that there's less than 150,000. You will do a CBC to exclude pancytopenia. Is there a pancytopenia? Is there not just platelets, but the CB is low and the TLC is low, and then there's a bone marrow problem, that means. Or you take the bone marrow smear to check for histology. The bone marrow is fine. Then you check for B12 levels. B12 can also cause low platelets. You do an ultrasound for any kind of leukemia or lymphoma that you're suspecting. You can do a retic count for bone marrow function. So depending on the cause, for example, if you feel that's just dengue, then you're going to do a viral dengue test. So depending on the history examination, you are going to do tests for the thrombocytopenia. Treatment of thrombocytopenia depends on the cause. In mild cases, treatment may not be needed. Platelet transfusions only needed if there's an active bleeding or there's a high risk of bleeding or is going for a surgical or some like surgical emergency and the indication of the platelet counts is less than 20,000. Coagulation disorders is hereditary, either quantitative or qualitative defect. Okay, so coagulation can be hereditary defect or an acquired defect. Hereditary, we'll talk about hemophilia and von Willebrand disease. These are the two that you guys should know. Acquired is multiple coagulation factors like DIC, liver disorders, and vitamin A. So hemophilia is an S-linked recessive disorder in which there's a deficiency of factor VIII. We just talked about it. The family history is often present. The bleeding time in PT is normal. The APTT is wrong. That is all that you need to know. If you see in a MCQ that the APTT is wrong, then that's hemophilia. Factor VIII, and then you do a serum factor VIII level, and that will be reduced. The therapy is to give factor VIII replacement. Von Willebrand disease, we just talked about it. This is important in platelet plug as well as in the fibrin clot, right? Because it's a carrier of it's a carrier of factor VIII. So increased bleeding time with normal platelet count or a decreased. So there will be an increased bleeding time with a normal platelet count, and there will be decreased factor VIII activity. So there'll be an increased bleeding and there'll be increased bleeding time, and the APTT is going to be prolonged. And that is when we say that there's a 1 milligram problem. And you can do a decreased by milligram concentration is going to be decreased. And then you replace it by 1 milligram injections. DIC is something that we are very, very horrified. It is an acquired syndrome characterized by coagulation problems and then a bleeding problem. So first, there is a systemic, widespread coagulation everywhere. So clotting, unnecessary clotting, abnormal clotting happens all over the body. Coagulation is the initial event. Then when everything is used up, all the clotting factors are used up, then the bleeding starts. And then the bleeding happens. And the most morbidity and mortality depends on the extent of the thrombosis, and there are multiple causes to it, but it's one of the horrifying diseases. So there's an activation of blood coagulation results in generation causation of fibrin, leading to thrombi and clots everywhere that causes organ dysfunction syndrome. And then after that, everything's exhausted, then it starts severe bleeding. So it's a horrible, uncontrolled thing. So there's activation of blood coagulation, then there's suppression of anticoagulant pathways, and there's impaired fibrolysis and cytokines are activated. Presence of disease associated with DIC. So first you need to know whether there and the clinical evidence of thrombosis or hemorrhage or both everywhere. So there's not one place you can have angina, then you'll have stroke. So factors disposing of conditions are malignancy, cardiovascular diseases, ARDS, like in COVID, we saw a lot of DICs in COVID because the patient went into an ARDS, acute respiratory distress syndrome. There's acidosis, transfusion reaction, sepsis, tissue injury, extensive surgery, and gynae ops. And see a lot of in eclampsia. We see this a lot in eclampsia. So this is what happens. Anything can happen. So they can be gangrene or they can be bruises. In cardiac, there can be infarcts or there can be intracranial bleeding. They can be renal necrosis or they can be hemorrhagic. So they can be myocardial dysfunction or dyspnea in hemorrhagic lungs. There can be ulcers and fast, there can be hemorrhage. So a lot of things can happen simultaneously. So there is no specific test. There's no specific treatment for it. But first, we are going to do the laboratory test. The thrombocytopenia, you see platelets low, you see prolonged rapidity. Every test of coagulation is abnormal. And this is how you remember. There'll be fibrinogen degrading products. So we do FDPs. There'll be positive D dimer. Positive D dimer is the one of the most important tests for TIC. There'll be low levels of all the coagulation inhibitors. There'll be low level of coagulation factors. So every test is abnormal. Management is number one. You stop the triggering process. You do chemotherapy, you stop the eclampsia, you control the cardiovascular problem, you control the ARDS. That is house winter. There's no specific management for it. If you see that there is a lot of bleeding, you can give plasma and platelet substitution. Right? If this, just, everything is just supportive. There's no specific treatment. If you see there's a lot of bleeding, you can do clotting factors. But sometimes it is difficult because you need to be doing both the things together. So this is something that you need to know about. Okay, thank you and see you in class.